Our next speaker brings with her an extremely unique experience. A lot of direct primary care today and direct care is being consumed and operationalized, I think, for supply and demand reasons, mostly with smaller employers, small to maybe mid-sized employers. Our next speaker, Sally Welborn, has done some incredibly innovative stuff at not just large companies, but the megas, right? So she headed up benefits at Wells Fargo, at Walmart, and is doing some very innovative things today. And she wants to share her perspective from organizations of that size and scale with this audience. Sally Welborn.
Thanks, everybody. So, wow, 5 o'clock. It's cocktail hour at a lot of places. So I'm going to try to move through this, and so because we have, I think, me and someone else, and then they have more panels. This is a tightly wound summit. I'm going to try to live up to that tightly wound. So I, as Michael introduced, most recently was at Walmart. I'm no longer at Walmart. I'm now out here in the Bay Area, consulting mostly with small entrepreneurial companies that are looking to make a difference in healthcare. But I want to chat with you a little bit about our experiences as a large employer. I'm going to use my outside voice because I think I just lost the mic. As truly a jumbo employer. I mean, yeah, Walmart is the biggest employer, I think maybe besides the Chinese Army.
This one's not hot yet, guys? There we go. Okay. I think the mic might have
died.
Carry on.
I could just use my outside voice and talk to you really loudly. Yeah. So at Walmart, we have about 2.2 million associates around the world, 22-ish countries. It changes every once in a while. And about 1.5 million associates in the United States. I will speak only about the United States, although I will tell you that some of the same things that we deal with in the U.S. also happens outside the U.S., but we'll just talk about the U.S. today. We have about 1.1 to 1.2 million individuals, men, women, and children, on our health plan. So we're bigger than a lot of insurance companies. Thinking about that, you would think, wow, that's so big, you must have so much leverage. The answer is we have zero leverage. The problem is we are fighting upstream against carriers, and I'm so glad that that's the word that's used. They're not payers, they are carriers. The employers write the checks. We are, quite frankly, fighting uphill against monopolistic health systems. And I'll use the provider word to encompass everyone, not just the doctors, the whole health systems that are monopolistic, sometimes duopolistic, but we're fighting upstream. We don't have a legislature or regulators that have any clue about how to help us. And so as large employers, we are kind of struggling, to be perfectly honest, and we're mad as hell, but we're struggling. So at Walmart, I think they titled my presentation about coloring outside the lines. And so I don't know that I would say it's coloring outside the lines, but I think what I would say is we didn't just try to work within the box. And my team and I, as we would think about what we needed to accomplish for the company, for Walmart, we wanted, first and foremost, to make sure that the associates and their family members that were on our health plan got the best care that they could possibly get. Now, our leadership always wanted that, I had never worked anywhere before. I came to Walmart in 2009, where the healthcare costs were actually part of the earnings reports. That kind of puts it in perspective when healthcare costs are part of the earnings statement. It wasn't about the cost of green beans, it was about the cost of healthcare. So we said, you know what, if we're going to impact healthcare, we can't wait for the system to fix it for us. We have to figure out how we can fix it for ourselves. knowing that we have zero leverage. We can't just do the typical, what everyone thinks about Walmart. Everybody thinks about Walmart. Two things. One, they are just going to beat it out of their suppliers, right? So we knew we couldn't do that. We have no leverage. And two, everybody thinks Walmart has terrible benefits. Well, I'm here to tell you they actually have really good benefits. It's not about trying to reduce the amount that the company pays, and so that can't be the solution, and we can't beat it out of our suppliers. So what can we do? So we recognized where we wanted to start. We know that, and you guys know this too, right? 80% of the cost comes from 20% of the people. And when you have no leverage, you have to figure out where you can spend your time and energy to get the most bang for your buck. So we said, well, clearly, if we can focus our energy on that smaller population, to impact 80% of the cost, let's start there. We also knew we were hearing anecdotally about our associates, our members, and our patients that were getting horrible care in their home facilities, just horrible care. We would get these stories that were just heart-wrenching. So we said, okay, we've got to get these patients to better care. Where are we going to start? Well, the obvious place to start was with spine, with orthopedic, because it was very, very clear what the evidence says about the treatment, the evidence-based medicine, and the cost variation was just off the charts. So we said, let's start there, let's dip our toe in the water and figure out how to get our patients to the highest quality providers, because we know there is a difference in quality and we know there's a difference in cost. So that's where we started. We had to identify first the best providers. Now, so that is a pretty big challenge because nobody has written the book on where the best providers are, and we're talking about a specialty within facilities. So we had to do a lot of really hard work to identify the best providers. So we identified a few facilities, and then we said, now, how can we make sure that these facilities are going to continue to operate and want to operate, not operate as in cut people, but operational, operate in an appropriate way? And that's our guiding principle. We're looking for appropriate care. So we applied a lot of filters, and one of the filters we applied was, how do they compensate the doctors and the surgeons and the people at the facility for doing their work? And one of the first criteria was we looked for facilities that paid the surgeons not by individual surgery, but by salary. They weren't incented to provide additional care. They were just incented to do the right care. And we could see through the data that we could accumulate that they actually seemed to do fewer surgeries. And when they did surgery, they had excellent outcomes. So that was how we got into this. We said, we just want to get our patients to the best care. It was not about how are we going to get a lower cost. It was about how do we get our patients to the best care. We wanted to compensate the facilities the right way. This isn't about trying to reduce cost just by beating it out of the vendors, right? This is about paying a fair price. And we negotiated bundles that, quite frankly, weren't that much different than what we would have paid had we been paying fee-for-service. It was just organized differently and included things like guarantees against readmission and things like that you would expect, but it wasn't that much more than you would pay on fee-for-service. The other thing we did, and this is kind of the more unique part of it that not very many people have done. We also negotiated a bundle for assessment. We didn't know at the time what this was going to mean, but we said, we think there may be some times when we're going to send a patient to you, the center, and you're going to assess the patient and say, probably they don't need surgery. So we want to make sure we're compensating the facility and the surgeons, the doctors, and the team in the right way, so we're going to compensate them even for doing that. So we created these assessment bundles. So we set off down this path. We have a completely, fully care teams at each center. We have a concierge model. We set up the benefit plan so that it's 100% paid for the patient to get there and for someone to come with them. No deductibles, no copays, nothing out of their pocket. We fly them across the country if they need to go across the country, put them up in a hotel, have somebody meet them at the airport, and are with them the entire time. So fast forward, we kick this thing off. It's a total voluntary program. If they don't want to do it, fine, but we're making it available. If you want to do it, we'll get you to the best care in America. Not long into it, we started seeing the volume of patients that were being told, you don't need surgery. You need physical therapy. You need pain management. You need something else, but you don't need surgery, and being sent home. So they're like, okay, well, that's really interesting. So how are we going to make sure they're getting home? Well, we have a doctor-to-doctor conversation when they're sent home. The team that's assessed them has a conversation with their primary care physician at the home facility, not the surgeon that sent them there, but the primary care physician, have a conversation about how to manage the patient. And we've now paid an assessment bundle to the facility. Patient is now sent home. So then we're like, okay, I wonder how many of them are going to go back to their surgeon and say, those old Wal-Mart people said I can't have surgery, so I know we're going to do this. The reality is less than 5% out of the 100, now, many years now forward, it's maybe less than 2% have gone back and had that surgery from their home physician. The reason is because they had a team that worked with them in person, spoke with them about alternatives, made sure that the patient returned home to the right primary care at home. So now it turns out that for spine surgeries, what we learned, half the time the patient actually doesn't need surgery when their home surgeon says they need surgery. That is just inappropriate care. We have doctors that are slicing people open that should never be in that situation. So Atul Gawande wrote a great article about one of our patients who ended up not needing surgery. It was in the New Yorker maybe 3 or 4 years ago. If you want to look it up, it's kind of a good story because it follows the patient, not the one who actually got the surgery, which are good. They're great surgeries, but it follows the patient that didn't get surgery, which is actually more of the story. And that is actually where we're getting cost savings. We are not paying for surgeries that shouldn't ever happen. Patients are not going through surgeries that should never happen. So this COE thing was kind of interesting. And we said, maybe we should start thinking about it for other body parts. And oh, by the way, it's kind of interesting to share the information with our colleagues at other companies. So we can't, for antitrust reasons, we can't tell our other companies how much our bundles are, but we can certainly share the architecture, how we create the bundles, how we created the COE, et cetera. So we shared that with a lot of other employers and helped them create their centers of excellence for hips and knees. Same thing, same approach, and oh, guess what? Everybody said, oh, you're not going to get that same situation where people are being sent for hips and knees that don't need it. Just, you're going to get a great outcome. You're going to get great surgery. Guess what? A third of the time, patients that are told they need hip or knee don't need it. It just continues to amaze us how that can be that American doctors are telling their patients, taking money from their patients, taking money from the golden goose employers, from Medicare, from your pocketbooks as taxpayers, right? That is care that should not be provided. It was been how many different presentations about 30% of the healthcare is waste? It's not waste. That's putting a lovely little word around it. It is inappropriate care. It's care that if they follow the evidence, if they follow what their own medical societies tell them, they follow the basic rules, they wouldn't be doing it. It's too nice to call it waste. It's harming people. And when we think about that at Walmart, and when I talk about that with my colleagues at other large employers, we're just apoplectic. It's like, how can that be? How can that be that that's what's happening? So I will tell you that at Walmart, we continued down the path then for cancer. A little bit different of an approach because cancer isn't quite so neatly bundleable. But here's the horrible outcome from that after just 2 or 3 years of the Cancer Center of Excellence. 55% of the time, the patients that go are told you have been given the wrong treatment protocol. 55% of the time. And 10% of the time, the patient has been told they have a cancer they don't have. Some percent of that, and I don't know what it is, they don't have cancer at all. So imagine we've got patients out there that are being told, you have cancer, you need to get chemotherapy and surgery and all kind of stuff that's going to make your life horrible, and they don't even need it. So we're really glad that at Walmart that we've given our patients access to top-tier physicians who can help them through and get them the right treatment, the right care, the right diagnosis, and we're thrilled to pay for them to get to that care. We pay 100% for them to get there. So again, it's not because Walmart has cheap benefits. We don't. We have great benefits. We pay 100% for those kind of things. So Centers of Excellence we thought it was kind of a basic foray, but it really opened our eyes and our energy into this whole concept of appropriate care and the fact that we have to do more to eliminate inappropriate care in the United States. So some other things that we've done, we moved on. Centers of Excellence is great, but you can't do it for a lot of stuff because people aren't going to run across the country for a lot of stuff. So we also are looking for great accountable care organizations because truthfully, if we had integrated systems with primary care, the right specialty, and access to the right centers for appropriate care for tertiary, quaternary care, that actually is first prize where the patient doesn't have to go across the country. So identifying a very small number of ACOs, because there's a ton of ACOs out there, and not very many of them actually deliver truly integrated care with better outcomes. So moving into the ACO direct contracting with the ACOs. One little element too, just by the way, when we do these direct contracts, the carriers, whoever we have, Aetna, United, Blue, they're not part of the contracts. The contracts are administered directly with the provider. And then we have a separate TPA that does all the administration because it's not appropriate for it to flow through the typical contracting that exists with the carriers. So that's sort of some of the things we've done at Walmart. I want to, other things that we do, I'll tell you, so this is kind of for all employers. All employers are searching and struggling for what can we do because our carriers aren't delivering to us what we need to solve healthcare quality and cost. So, like I said, what I'm doing now, a lot of my time is spent with entrepreneurs starting up little companies that are going to solve a piece of the healthcare system. It's because employers and payers, mostly employers, are looking for something else to fix everything because the carriers aren't providing it to us. So there are tons of solutions. There are companies like Grand Rounds, Castlight, Livongo, Omada. We've got diabetes care, we've got chronic condition care, we've got the Transparency, Castlight, we've got Second Opinion, Second MD, Grand Rounds, all of these, Carum Health, bundle payments, Vivanti Health, Vivio Health on specialty pharmacy. That's 5 of hundreds that are sprouting up out there that are not coming through the carriers. And large employers are interested in these small companies because they're willing to go through what it takes to add them to their supplier list, to incorporate them in because they're willing to bring in the solutions for their patients so that their patients can get good quality care, because they're not getting the good quality care. I'm sorry, guys, the doctors out there in the audience, they're not getting good quality care from their physicians. So we're layering on, and doing it not so gladly, but doing it because it's the right thing to do, because we want our patients and our employees to get good quality care. So, DPC. So my confession is that, so I was introduced to HINT because I read Dave Chase's book. I reached out to Sean and Dave, and I said, oh, this is really interesting, kind of intrigued by it, and let's have a conversation. We had a little conversation, and in the course of the conversation, they said, oh, you should meet the guys at HINT. So I said, oh, okay. So I went to meet the guys at HINT, and we're sitting down there. They started the conversation about DPC, blah, 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 DPC, blah. I'm like, what? Wait. Okay, this is like a few months ago. I go, what's DPC? Right now, I have been in the employee benefits industry since dirt, and I was at Walmart. We did all of this stuff. I've been involved with innovation and all that. DPC is not an acronym that is in the large employer's lexicon. So just so you know that. It might be in the lexicon of smaller employers in certain locations, but it is not in the lexicon of large employers. So you've got a huge uphill battle if you come out talking about DPC, because we don't know what the heck you're talking about. So, but I will tell you also, I think that the model and the way that you guys are kind of organizing yourselves is going to be truly, truly difficult to deliver to jumbo employers that are geographically dispersed. And most jumbo employers are geographically dispersed. Now, you're going to have a few that are, have a density in a particular geography. So some of us might remember an HMO phase in our past, and there was a time when employers had some of the jumbo, I think it was GE that had like 125 HMOs at one time that they were trying to manage, and finally said, this ain't gonna work, right? And there were a lot of reasons that HMO things didn't work, but part of it was employers couldn't manage 125 different HMOs. So think about that with DPC, I now have a new word now, DPC, where we have all these little provider systems or doctor systems or whatever they are that are sprinkled all over the country that are not integrated with any integrator. And it's going to be really difficult for the jumbos to be able to walk down that path. Now, I saw that Boeing is talking to something with IORA, but that's a very one-off, and Boeing will be a first mover if there's a first mover. And there's a handful of us that are first movers, and so they may be. I'm going to call them and see what they're doing. But I'm just here to tell you that DPC is going to be an uphill battle with the jumbos to do something nationally. Now, they might be able to do things in a region, small bits and pieces if they have large populations, but it's going to be hard to do it nationally. So my parting words are, it's not going to be impossible. There are first movers that start things like consumer-directed health plans. Many years ago, we started that a long time ago, and who doesn't have one today? There were a few of us that did it back then. So there were a few of us that did things like Center of Excellence. That's going to become more ubiquitous. There will be a few first movers that are going to do things potentially with things like direct ACOs. Potentially, you want to be in the room and be at the table with the DPC, because there will be some jumbos that will at some point want to move in that direction. So focus on, you guys are in a different position. You're in the primary care, right? And the big waste, the big loss is in the specialty care. And to the extent that you're impacting that, and you can prove the impact on specialty care, I'm not talking about reducing emergency room visits, but to the extent that you can make sure that your patients are getting to the providers, specialists, who are only going to provide appropriate care so that you can manage the patient appropriately, then you will really have made a difference in healthcare in America.